Welcome to the deep dive. We've got quite a stack of sources today, a real mix, everything from advanced clinical notes to some core physiology studies. And it's all focused on, well, cardiovascular emergencies, the heart under pressure. Our mission here is to really dig deep into how the heart responds when things go wrong systemically. We want to get past just the basics of heart failure. We're aiming to pull out those key nuggets of knowledge about stress mechanics, volume overload, stiffness, and then the big one, systemic shock. We really need to understand those high-yield clues, the sounds, the labs, the hemodynamic fingerprints that tell us what kind of failure we're actually looking at.
Yeah, it's a crucial mission because in cardiovascular care, getting the diagnosis right, well, it often dictates the immediate life-saving steps you take.
Yeah.
So we're connecting the dots today. We'll start by decoding the heart's language, those subtle sounds like S3 and S4. And we'll look at the power of labs like BNP. Then we'll get into the different types of heart failure, low output, high output.
And I find that contrast really interesting. We usually think of heart failure as just a weak pump, right? Struggling. But we're going to spend some real time on high output failure, where the heart's actually pumping like mad, but the system, the pipes fail anyway. It's paradoxical.
Precisely. And we'll wrap up by looking at the four main shock syndromes using their hemodynamic profiles to tell them apart. And then critically, the pillars of long-term survival in heart failure, including some drug danger zones everyone really needs to be aware of. It's about putting it all together. Let's dive in.
Okay, let's start where really every good cardiovascular assessment begins. The physical exam. Our sources really hammer home that certain heart sounds, maybe ones people think are hard to hear, are actually high-yield clues. They tell you a lot about the ventricle, right? We're talking S3 and S4 gallops. Let's tackle S4 first. What's that telling us?
Okay, S4. Think resistance. Think stiffness. It happens really late in diastole, just as the atrium contracts, pushing that last bit of blood into the ventricle, right before S1. In a healthy heart, you don't really hear that final push. It's quiet. But with an S4, that atrial contraction is basically slamming blood against a really stiff, non-compliant left ventricular wall. That vibration, that's the S4 sound. It's a key sign of diastolic dysfunction. The ventricle just isn't relaxing properly to fill up. You see it a lot with long-term, maybe poorly controlled hypertension. That pressure makes the LV walls thicken up concentrically. It's fundamentally a pressure problem. The mnemonic people use for that rhythm is often Tennessee.
Okay, so S4 means structurally we're likely looking at a thick, stiff muscle wall.
Yeah.
That's a hallmark of HFpEF heart failure with preserved ejection fraction.
Exactly. That's the classic association.
And is S4 ever normal, or is it always bad news?
Well, almost never in someone over 70. And it's considered highly pathological in younger adults. If you hear an S4 in an adult, your first thought should really be hypertensive heart disease. And you should definitely consider HFpEF. Now let's contrast that with S3, which signals a completely different mechanical issue. S3 happens much earlier. It's an early diastole right after S2. People often call S3 the ventricular gallop. What it means is that blood is rushing in rapidly, passively into a ventricle that's already enlarged and overloaded with volume.
Ah, okay, so S3 is like a volume sloshing into a big, maybe thin-walled, floppy chamber, whereas S4 was that resistance against stiffness.
That's a perfect way to put it. Because the ventricle is dilated and volume overloaded, S3 is highly specific for LV systolic dysfunction, meaning the pump itself is weak, dilated, failing. That's your classic picture of decompensated HFrEF heart failure with reduced ejection fraction. The mnemonic for S3, that rhythm, is Kentucky KY stir. So the key difference, bottom line, S4 is pressure stiffness, S3 is volume mutilation. Just those two sounds can really point you towards the type of heart failure.
That's incredibly useful, actionable knowledge right there at the bedside. Okay, moving from sounds I can hear to biochemistry. Let's talk BNP, brain natriuretic peptide. How does this work as a sort of diagnostic barometer for ventricular stress?
Right, BNP. It's released directly by the heart muscle, the ventricular myocardium, specifically when it's under increased wall stress. That physical stretch and pressure we were just talking about. It's actually the body trying to help itself. BNP promotes getting rid of sodium and water natriuresis, and it causes vasodilation, trying to relieve that pressure overload. Diagnostically, yeah, a BNP over 100 picograms per milliliter suggests heart failure. But here's the real high-yield piece our sources emphasize. The most powerful use of BNP is actually ruling out heart failure. A normal BNP, less than 100, has an extremely high negative predictive value. So if a patient comes in breathless, they're not obese, and their BNP is low, you can be pretty darn confident it's not heart failure causing their shortness of breath.
Okay, that makes perfect sense. The lab value for stretch, BNP, lines up with the sound of stretch, the S3 gallop.
Precisely. They're both reflecting high filling pressures, just measured differently. Now let's think about signs of that volume backing up systemically. We need to cover hepatojugular reflux, or HJR. HJR is a physical finding that's very, very specific for right ventricular failure, RV failure. How you check it is you press firmly on the upper abdomen and you watch the neck veins, the jugulars. If the jugular venous pressure rises more than 3 centimeters and stays up while you're pressing, that's positive HJR. The mechanism is straightforward. Compressing the abdomen pushes extravenous blood back towards the heart. A healthy RV just handles it. But if the RV is failing, it can't cope with that sudden extra volume. So the blood immediately backs up into the vena cava and then the jugulars, making them distend. It's a key sign of RV dysfunction, systemic congestion.
That's a great visual. Pump failure leading straight to backflow. But beyond the physical exam, our sources flag a really important prognostic marker in the blood. Low sodium. Hyponatremia. Why is low sodium such a bad sign in heart failure? It seems counterintuitive when they're volume overloaded.
It does seem counterintuitive, but hyponatremia, let's say sodium below 130, is a really strong independent predictor of poor outcomes, higher mortality, especially in HFrEF. And the reason why tells you just how stressed the whole system is. In really severe HFrEF, the low cardiac output tricks the kidneys. They think the body doesn't have enough circulating volume, even though the person's actually drowning in fluid. This kicks off massive neurohormonal activation. RAAS goes wild, and critically, ADH antidiuretic hormone, vasopressin release, skyrockets. ADH tells the kidneys to hold on to free water. Just water, no sodium. So the body retains all this extra water, which then dilutes the sodium that's already there. That's dilutional hyponatremia. So seeing low sodium means the neurohormonal system is firing on all cylinders, desperately trying to retain fluid in a way that's actually making the heart failure worse. It's a vicious cycle indicator.
Wow. Okay, so it's a marker of just how desperate the body's compensation mechanisms have become.
Exactly, a really ominous sign.
Right, we've got the markers. Let's dive into the actual types of low output failure. HFrEF and HFpEF, reduced versus preserved ejection fraction. What are the key differences in what's actually going wrong mechanically, the structure?
Okay, HFrEF, reduced EF, usually 40% or less. That's the one most people think of. The pump is weak, the walls are often thin, the chamber's dilated, like a stretched out balloon. This often happens after a big heart attack, ischemic damage, or maybe chronic volume overload. It leads to what we call eccentric hypertrophy. The chamber gets bigger. HFpEF, preserved EF, 50% or more, is physiologically really different and frankly often tougher to treat. Here the problem is stiffness. The ventricle is hypertrophied concentrically. The walls thicken inwards, making the chamber smaller and stiff. You can't relax and fill properly, the most common cause, chronic hypertension. Years of pumping against high pressure thickens the muscle. But also, our sources really point to systemic inflammation, particularly linked to obesity and being sedentary, driving myocardial fibrosis. This is why HFpEF is becoming, well, much more common.
That difference in structure, the stiffness in HFpEF, makes those patients really vulnerable to changes in their heart rhythm, doesn't it? The sources mention the atrial kick specifically. Why is losing that kick such a big deal for them?
It's absolutely critical for them because that stiff HFpEF ventricle resists passive filling from the atrium. The heart really relies on that final coordinated atrial contraction, the atrial kick, to shove that last maybe 20% of blood into the LV right before it pumps. If they suddenly flip into a rhythm like atrial fibrillation, AFib, they lose that coordinated kick completely. Without that final push, LV filling plummets, cardiac output tanks almost instantly, and they can spiral into acute decompensated heart failure very, very quickly. They are incredibly dependent on normal sinus rhythm.
Got it. Highly dependent on that last squeeze from the atrium. Now let's swing back to the classic HFrEF cycle. Pump fails, body tries to compensate, but the compensation actually makes things worse long term. Can you unpack the role of the RAAS system, renin-angiotensin-aldosterone system, in that maladaptive cycle?
Right, the RAAS. In systolic failure, HFrEF, the low output signals the kidney, hey, we're dehydrated, even though they're not. So the kidney releases renin. Renin starts the cascade leading to angiotensin II. Now, angiotensin II is a potent vasoconstrictor systemically, which raises blood pressure and SVR, systemic vascular resistance. But the really crucial part, the bit that drives the cycle in the kidney itself, is its effect on the arterioles within the glomerulus. Angiotensin II preferentially constricts the efferent arteriole, That's the little vessel leaving the glomerulus.
Okay.
By clamping down on the exit, it artificially jacks up the pressure inside the glomerulus. This does initially help maintain the glomerular filtration rate, the GFR. It's a short-term fix, but chronically. This intense efferent clamping plus the systemic vasoconstriction dramatically increases the heart's workload, the afterload. Pushing against all that resistance, plus the volume retention driven by aldosterone later in the cascade, just wears the already weak heart out even faster.
Yeah.
It's a perfect example of a short-term fix becoming a long-term disaster.
Right, a truly vicious cycle. Which brings us perfectly to the fascinating flip side. High output heart failure. This is where the heart is actually pumping more than normal high cardiac output, but the patient still ends up congested, short of breath, like in regular heart failure. What's the core breakdown here?
The core breakdown, the fundamental problem in high output failure, isn't the pump, it's the pipes. The systemic vascular resistance, the SVR, is persistently and radically low. The blood vessels are just too wide open systemically. So to maintain enough blood pressure to perfuse the organs against virtually no resistance, the heart has to beat much faster and pump much harder. This chronic state of overdrive, high flow, high venous return eventually just overwhelms the heart muscle, leading to dilation, failure, and those classic volume overload symptoms like edema.
Okay, let's look at the classic examples. First up, hyperthyroidism. How does too much thyroid hormone manage to cause heart failure?
Thyroid hormones, especially T3, ramp up metabolism everywhere. But hemodynamically, they act a lot like having massive sympathetic nervous system stimulation all the time. This causes widespread vasodilation in the periphery, which tanks the SVR, massively drops it. To compensate for that loss of resistance and maintain blood pressure, the heart rate shoots up, and contractility, how hard the heart squeezes, goes way up too. Clinically, you see this hyperdynamic circulation. The patient might have warm, moist skin, bounding pulses, and a really noticeable wide pulse pressure. That means a high systolic pressure but a very low diastolic pressure. This constant high flow state, this flow burden, eventually just wears out the ventricle, causing it to dilate and fail. And the treatment, interestingly, isn't primarily cardiac meds at first. It's treating the thyroid problem itself.
Treat the source. Okay. And the second big example is more of a plumbing issue. The arteriovenous fistula, or AVF. Seems simple, but big consequences.
Yeah, it's pure hydraulics, really. An AV fistula is a direct shortcut, a connection between a high-pressure artery and a low-pressure vein. It completely bypasses the normal high-resistance network of arterioles and capillaries.
Like a short circuit in the system.
Exactly, a short circuit. This causes an immediate, often dramatic drop in the overall SVR, the afterload. And because blood rushes back to the heart faster through this low-resistance path, it also causes a big jump in venous return, the preload. So the heart is hit with less resistance to pump against, but way more volume coming back. The net effect is it has to drastically increase its cardiac output to handle this shunt. Now, small AVFs, like the ones created for dialysis access, are usually okay. But large ones, maybe from trauma or congenital, force such a massive, sustained increase in cardiac output that you start seeing those high-output heart failure symptoms. The wide pulse pressure again, and enlarged heart on imaging, and eventually signs of failure like pulmonary and peripheral edema. And if the problem is plumbing, the fix has to be plumbing surgically closing or reducing the size of that fistula.
Makes sense. Fix the leak, fix the flow. Okay, let's shift gears now to outright shock when tissue perfusion fails. Here, getting the diagnosis right fast is absolutely critical. Our sources give us a great framework using 3 key hemodynamic numbers. Before we jump into the patterns, can you just quickly remind us what those 3 variables actually mean clinically? CI, PCWP, SVR.
Absolutely. These numbers are the bedrock of differentiating shock states. Without them, you're guessing. So, 1, cardiac index, CI. This measures pump function, how much blood the heart is actually pushing forward per minute, adjusted for body size. Low CI means the pump is weak or isn't getting enough volume. 2, pulmonary capillary wedge pressure, PCWP. This is our best estimate of LV, preload, and backup pressure. It reflects the pressure in the left atrium, essentially. High PCWP means the LV is overloaded, suggests congestion, fluid backing up into the lungs. Low means the tank might be empty. 3, systemic vascular resistance, SVR. This measures plaque tightness, the resistance the blood vessels are putting up against flow. High SVR means the vessels are clamped down tight, think cold, clammy patient. Low SVR means they're wide open, dilated, think warm, flushed patient.
Perfect. Pump, preload, pipes. Okay, let's use that framework. Differentiate the big 3 shock syndromes, starting with the classic pump failure. Cardiogenic shock.
Right. Cardiogenic shock. Usually after a big heart attack, the pump itself fails. So 1, CI is low, the damaged muscle just can't pump effectively. 2, PCWP is high, blood can't get pumped out, so it backs up into the left atrium and the pulmonary vessels, congestion. 3, SVR is high. The body freaks out because of the low output and triggers a massive sympathetic response, releasing catecholamines that clamp down all the peripheral blood vessels trying to maintain pressure to the vital organs.
Hmm.
Clinically, this patient is hypotensive, yes, but they're also cold, clammy, maybe mottled skin, because all the blood is being shunted away from the periphery due to that high SVR.
Got it. Low pump, high backup, tight pipes. Now contrast that with hypovolemic shock at the empty tank.
Okay, hypovolemic shock, massive bleeding, severe dehydration, whatever the cause, volume is gone. So, 1, CI is low, can't pump what you don't have, output drops. 2, PCWP is low, the tank is empty, there's no preload stretching the LV. 3, SVR is high. Just like in cardiogenic, the body tries to compensate for the low volume and pressure by clamping down hard.
Okay, so low pump and tight bikes again, but the key difference is that preload, the PCWP.
Exactly. That low PCWP is the critical differentiator. And it dictates completely opposite management, right? For hypovolemic shock, you pour in fluids immediately. For cardiogenic shock, you're usually restricting fluids, maybe using diuretics or pressors. That PCWP tells you which way to go.
Crucial distinction. Okay, third type, distributive shock, sepsis, anaphylaxis. Here the problem isn't pump or volume, it's the pipes themselves failing.
Right. Distributive shock. Think massive vasodilation. The pipes are just way too open. So,
Yeah.
1, SCR is dramatically low. That's the defining feature. Inflammatory mediators, histamine, whatever, cause widespread vasodilation. 2, PCWP is usually low. Fluid leaks out of the leaky capillaries, plus the vasodilation means less effective circulating volume getting back to the heart. 3, CI is often high, at least early on. If the patient's heart muscle is healthy, it tries like crazy to compensate for the non-existent SVR by pumping much faster and harder, trying to fill those leaky, wide-open pipes.
So this patient looks totally different, maybe warm, flushed, bounding pulses initially, unlike the cold cardiogenic patient.
Exactly. That low SCR, often with high cardiac output initially, is the key fingerprint of distributive shock. And just for contrast, obstructive shock, like a massive PE or tamponade, also gives you low CI and high SVR, but the cause is a physical blockage, not pump failure or empty tank.
Okay, let's focus on 2 distributive crises that need immediate action. Anaphylaxis. This is terrifyingly fast.
It is. Anaphylaxis is an IgE-mediated disaster. Mast cells and basophils just dump massive amounts of histamine, leukotrienes, other mediators. These cause that systemic vasodilation boom, SVR drops. And they cause capillaries to leak like sieves. That's where the angioedema, the swelling comes from, and why the PCWP drops. Leads to rapid hypotension. Clinically, there is one absolute priority: immediate intramuscular epinephrine. Full stop. Epi's alpha-1 effect causes rapid vasoconstriction, counteracting the vasodilation, bringing the SVR and blood pressure back up. These beta-2 effects help open the airways and also reduce further immediate release. Delaying epinephrine, thinking, oh, let's try antihistamines or steroids first, that is a potentially fatal mistake. Epi reverses the vascular collapse. Nothing else does it as quickly or effectively.
Don't delay epi. Got it. Now, contrast that rapid bomb going off with something maybe more insidious but just as deadly. Adrenal crisis. Often missed, apparently.
Yeah, acute adrenal insufficiency or adrenal crisis can be tricky. It happens when someone lacks cortisol, and often aldosterone too, usually during a period of high stress, like illness or surgery. The lack of cortisol itself contributes to vascular collapse hypotension that often just doesn't respond well to standard vasopressors. The lack of aldosterone causes salt wasting, leading to hypovolemia, which worsens the shock. You often see a classic clinical triad. 1, severe refractory hypotension. 2, hypoglycemia, low blood sugar. And 3, characteristic electrolyte changes. Hyponatremia, low sodium, and hyperkalemia, high potassium. Plus maybe a history of fatigue, weight loss. Because cortisol is essential for maintaining vascular tone and the body's stress response, management has 2 immediate pillars. First, aggressive 5E fluid resuscitator to deal with the hypovolemia. Second, and crucially, IV glucocorticoids, usually hydrocortisone. If you even suspect adrenal crisis in a patient in shock, you give the steroids empirically. You cannot wait for confirmatory blood tests like ACTH or cortisol levels. The risk is too high. Treat first.
Wow, another situation where you have to act before you have all the data. Okay, before we move off shock, we absolutely have to cover that specific cardiac failure scenario that requires seemingly counterintuitive treatment, right? Ventricular myocardial infarction, RVMI, the preload trap.
Ah, yes, the RVMI. Very dangerous, often happens alongside an inferior wall STEMI. When the right ventricle gets infarcted and fails, it simply cannot pump blood effectively forward into the pulmonary artery and onto the left ventricle. The critical downstream effect is a sudden severe drop in left ventricular preload. The LV just isn't getting enough blood delivered to it. It has nothing to pump, leading to profound hypotension. The classic clinical picture is hypotension, yes, jugular venous distension, JVD, because blood is backing up from the failing RV into the neck veins. But, and this is the key, the lungs are clear on auscultation.
Clear lungs, because the problem is before the lungs.
Exactly. The traffic jam is before the pulmonary circulation, so the lungs don't get congested. That combo hypotension, JVD, clear lungs, screams RVMI.
And the management completely hinges on understanding that mechanism, right?
It absolutely does, because the core problem is lack of LV preload. The number one critical life-saving intervention is to aggressively increase RV preload.
How?
With IV normal saline boluses, you are literally trying to force feed volume into that struggling RV to get something across to the LV. It's one of the few shock states where pouring in fluid is the primary way to raise cardiac output. And conversely, the absolute do-nots are critical. Avoid nitrates, diuretics, and opioids at all costs. Why? Because all three of those reduce preload. In a patient whose LV is already starved for preload because of the RVMI, taking away even more volume with these drugs can cause immediate catastrophic cardiovascular collapse and cardiac arrest. It's incredibly dangerous.
Okay, fluids, yes. Preload reducers, absolutely no. A vital distinction. Let's shift now to the patient who comes in with acute decompensated heart failure, ADHF. They're often presenting with that flash, pulmonary edema, can't lie flat, orthopnea, waking up gasping, PMD crackles all over their lungs. What are the first things we need to do to pull them back?
ADHF with pulmonary edema is basically the LV pressure being so high that fluid is forcing its way into the air sacs, the alveoli. They're drowning from the inside. So, immediate goal, reduce that preload fast. First steps are always supplemental oxygen, get their SATs up, and then immediate, often aggressive, IV loop diuretics, furosemide usually. Get that extra volume off quickly. Now, for patients who are really struggling to breathe in acute respiratory distress, our sources strongly recommend non-invasive positive pressure ventilation, NIPPV, that's BiPAP or CPAP, often as the first line before thinking about intubation. NIPPV does more than just push oxygen in. That positive pressure physically counteracts the high hydrostatic pressure in the capillaries, helping to push the edema fluid back out of the alveoli. And crucially, NIPPV also acts mechanically to help the heart. It reduces preload by slightly impeding venous return to the chest. And it reduces afterload by increasing intrathoracic pressure, making it easier for the LV to eject blood. So it improves oxygenation and unloads the heart. It's a powerful tool.
Right, it's doing double duty, helping breathing and helping the heart's workload. That's huge. And just as important, what should we absolutely not do in this acute setting?
The big one, the cardinal rule, do not initiate IV beta blockers acutely. Beta blockers slow the heart and reduce contractility, they're negative inotropes. Starting them when someone is already acutely decompensated, when their pump is struggling, that can absolutely crash them. Beta blockers are essential for chronic, stable management, but they are poison during the acute crisis. Also, things like inotropes, dobutamine, milrinone, they're reserved strictly for patients who are not just congested, but also in cardiogenic shock, meaning they have signs of low output, like hypotension and poor perfusion. If the patient's blood pressure is okay or even high, you focus on diuretics and maybe vasodilators first.
Okay, stabilize first, don't worsen the pump acutely. Makes sense. Once the patient is stabilized, we get into the long-term game for HFrEF. This is where we can actually change the course of the disease. The sources highlight 4 key drug classes that do more than just help symptoms, they actually reduce mortality. The 4 pillars, let's make sure we understand each one.
Yes, these are the game changers. They work by interrupting those bad neurohormonal cycles, preventing the heart muscle from remodeling in harmful ways, and ultimately they help people live longer. Pillar 1, RANS blockade. This includes ACE inhibitors, like lisinopril, ARBs, like losartan, and the newest class, RNIs, angiotensin receptor neprilysin inhibitors, specifically sacubitril and valsartan. ARNIs are kind of special. The valsartan part blocks angiotensin II, like an ARB, but the sacubitril part inhibits an enzyme called neprilysin. Neprilysin normally breaks down beneficial peptides like B and P. So by blocking it, you increase levels of these good peptides, adding vasodilation and natriuresis on top of the RAS blockade. They've shown superior outcomes to ACE inhibitors alone. Pillar 2, beta blockers, but only specific ones proven in trials. Carvedilol, metoprolol, succinate, a long-acting one, not tartrate, and bisoprolol. These absolutely must be started low dose and only titrated up slowly once the patient is stable and not volume overloaded. They work by shielding the heart from the toxic effects of chronic adrenaline and sympathetic overdrive, slowing the heart rate, improving filling time, and preventing harmful remodeling. Pillar 3, mineralocorticoid receptor antagonists, MRAs, that's spironolactone or Ipilino. They block the effects of aldosterone. Aldosterone doesn't just cause salt and water retention, it also directly promotes fibrosis, scarring, and stiffness in the heart muscle. So blocking it provides a mortality benefit beyond just diuresis. Pillar 4, SGLT2 inhibitors. Drugs like dapagliflozin and empagliflozin. These were originally diabetes drugs, but it turns out they have amazing benefits in heart failure, reducing mortality and hospitalizations. And importantly, they work across the spectrum, in HFrEF and now showing benefit even in HFpEF. The exact mechanism is still being fully worked out, but it likely involves better volume control, reduced cardiac fibrosis, maybe improved cardiac metabolism. They've quickly become absolutely foundational.
4 pillars for survival. That's a powerful combination. Let's contrast those quickly with drugs that are definitely useful, but mainly for symptoms, not survival.
Right. The main ones there are the loop diuretics, furosemide, bumetanide, torsemide. Absolutely essential for managing fluid overload, congestion, shortness of breath. They make patients feel better, keep them out of the hospital sometimes, but they don't change the underlying progression or improve long-term mortality. Digoxin is the other one. It can reduce hospitalizations for heart failure and helps control heart rate and AFib, but again, no proven survival benefit. It's more of a symptom control drug.
And digoxin perfectly tees up the next topic, drug danger zones. It's notorious for its narrow therapeutic window. What are the key non-cardiac signs that should make us worry about digoxin toxicity?
Yeah, digoxin toxicity is a classic trap, especially in the elderly or people whose kidney function changes. It works by inhibiting the Na plus K plus ATPase pump in cells. Too much inhibition causes problems everywhere. While cardiac arrhythmias are the most dangerous effect, often the first clues are non-cardiac. Think GI symptoms, really profound anorexia, loss of appetite, nausea, vomiting, and neurologic changes. Confusion, fatigue, lethargy, and the classic one, visual disturbances, seeing yellow or green halos around lights, or just blurry vision. If any patient on digoxin, especially an older one, suddenly develops those GI or neuro symptoms, you have to check a digoxin level and consider toxicity immediately.
Good flags to watch for. And the other major drug alert involves that newer ARNI class, sacubitril/valsartan, and the risk of angioedema. Why is this specific side effect so dangerous, and why don't normal allergy treatments work?
This is a potential airway emergency, no question. Remember, sacubitril inhibits neprilysin. Neprilysin breaks down bradykinin. So if you inhibit neprilysin, bradykinin levels go up. Bradykinin is a potent vasoactive substance that can cause localized capillary leak and swelling. When this happens in the lips, face, tongue, or crucially the larynx, you get angioedema.
And the swelling can close off the airway.
Exactly. And because this swelling is driven by bradykinin and not by histamine like in a typical allergic reaction, treatments like antihistamines and steroids are completely ineffective. They just don't work. Management is immediate. Stop the ARNI immediately. Get the patient to an emergency department urgently for airway monitoring and potential intervention. The swelling can progress incredibly rapidly. Never underestimate angioedema from an ARNI.
Okay, bradykinin mediated, not histamine. Critical difference in management. Let's broaden our view again now to how the heart interacts with other systems. Cardiorenal syndrome, the heart and kidney hurting each other. How exactly does heart failure mess up kidney function?
It's really a double whammy for the kidneys. First, the obvious one. The failing heart, especially the LV, leads to decreased forward flow. Less cardiac output means less blood flow perfusing the kidneys, which can impair their function. But the second mechanism, often underappreciated but really critical, is increased renal venous pressure. Think about it. If the right side of the heart is congested, pressure backs up through the vena cava, right into the veins draining the kidneys. High pressure in those renal veins creates back pressure against glomerular filtration. It's like trying to filter fluid into a pipe that's already full and under pressure. It drastically reduces the kidney's ability to filter waste, lowering the GFR.
So it's both reduced inflow and impaired outflow causing the kidney injury.
Precisely. That venous congestion component is huge.
Which leads to that management paradox we touched on. We often hesitate to give diuretics if the creatinine is going up, thinking we'll hurt the kidneys more. But here, in the context of congestive cardiorenal syndrome, where the patient is clearly volume overloaded, that rising creatinine might actually be due to the high venous pressure squashing the filtration gradient. In that specific situation, giving IV loop diuretics can actually help the kidneys. By reducing the central venous congestion, you lower the renal venous pressure, you restore that filtration gradient, and the GFR can actually improve. The creatinine can come down. It highlights why you have to look at the whole patient, the whole hemodynamic picture, not just one lab value in isolation.
Treat the congestion to help the kidney. Fascinating. Okay, finally, let's touch on a couple of specific systemic diseases that directly attack and infiltrate the heart muscle, starting with amyloidosis. Amyloidosis is fundamentally a protein misfolding disease. Abnormal insoluble protein fibrils get deposited in various organs. When they deposit in the heart muscle, the myocardium, they make the walls incredibly thick and stiff. This causes restrictive cardiomyopathy. It's an extreme form of diastolic dysfunction. The ventricles just can't relax and fill properly at all. It behaves a lot like severe HFpEF, often with that S4 sound we talked about. Because amyloid is systemic, our sources point out a classic diagnostic triad to look for. 1, the restrictive cardiomyopathy picture, plus 2, nephrotic syndrome, meaning massive protein loss in the urine leading to edema, often signaled by heavy proteinuria on a urine test. And 3, characteristic skin or bleeding signs like periorbital purpura, bruising around the eyes, like raccoon eyes, or just generally easy bruising. Seeing those three together should definitely make you think amyloid.
Restrictive heart, leaky kidneys, easy bruising. Got it. And our last specific example is an infectious one with a distinct geography, Chagas disease.
Right, Chagas is caused by a parasite, Trypanosoma cruzi, which is endemic mainly in Central and South America. Years after the initial infection, a chronic phase can develop. In the heart, this chronic infection leads to progressive inflammation and eventually extensive scarring, or fibrosis. The result is typically a severe dilated cardiomyopathy. So, unlike amyloid causing stiffness, Chagas usually causes a big, weak, floppy heart, classic HFrEF, low EF, often S3 sound. But here's the key association, the diagnostic flag, especially if you see a patient who has emigrated from an endemic area. The parasite also often attacks the autonomic nerves controlling the gut. This nerve damage leads to severe GI motility problems, classically manifesting as megaesophagus, a massively dilated esophagus, and/or megacolon, a massively dilated colon. So if you encounter a patient with dilated cardiomyopathy and signs of huge GI tract dilation, chronic Chagas disease should jump right to the top of your differential diagnosis. It's a classic bearing.
Dilated heart plus dilated gut points to Chagas. Another important connection. Wow. What a deep dive that was. We've gone from listening for subtle heart sounds, S3 and S4, telling us about volume versus stiffness, all the way to the really complex life and death hemodynamics that separate different types of shock. I think the big takeaway weaving through all these sources is just how integrated the cardiovascular system is. It's all about pressure, resistance, volume. You really can't understand or treat one piece without considering the whole picture.
Absolutely, and that differentiation based on the full picture is everything in an emergency. We saw how getting that hemodynamic profile right, the CI, PCWP, SVR, is the absolute key. Does this shock patient need fluids, like an RVMI or hypovolemia? Or do they desperately need preload reduction, like an ADHF, or maybe pressors in cardiogenic shock?
Yeah.
Or vasodilators reversed, like an anaphylaxis? The numbers guide the immediate critical actions. Integrated knowledge truly saves lives here.
And we spent a good chunk of time looking at how failures elsewhere in the system, hormones like thyroid or cortisol, or maybe structural issues like an AV fistula, can masquerade as primary heart problems, causing high output failure or refractory shock. So let's leave you, the listener, with this final thought to chew on. If the body's pipes, the vascular resistance, and its hormone signals can be powerful enough on their own to completely crash the circulatory system, even when the heart muscle starts out okay, does the future of really advanced cardiovascular medicine lie less in just trying to prop up a failing pump and maybe more in achieving exquisitely fine-tuned control over the entire systemic environment, the resistance, the volume, the neurohormonal balance? Keep digging into those complexities. We'll see you for the next deep dive.